Good afternoon and welcome to today's webinar, Colorectal Cancer Screening, the State of the Science in Nevada. My name is Brandy Johns and I'm the Training and Development Coordinator for Nevada Primary Care Association. This training is in partnership between Nevada Primary Care Association and the American Cancer Society. I just wanted to take a moment to thank our local American Cancer Society staff partner, June Hunter, who helped coordinate this session with us. The Nevada PCA values our partnership with the American Cancer Society. Before we get started, I would like to go over a few items with you. During the presentation, please make sure that you mute your phone or computer so that we don't have feedback or background noise. Also, please be sure not to put your phone on hold or we'll hear your hold music. You will have the opportunity to submit your questions to today's presenter by typing your questions into the chat control panel. You can send your questions in at any time during the presentation. June Hunter from the American Cancer Society will be monitoring those during the presentation. And then Dr. Brooks will be answering some of those as he goes, and others will be addressed at the end of the Q&A session. And when we do it at the end of the presentation, we're going to have everybody muted, and we ask if you have a question to raise your hand in the box over by your name. And that way you can ask the question and we can hear just you and not all the background noise. There we go. The University of Nevada has School of Medicine designates this live activity for a maximum of 1 AMA PRA Category 1 credit. This training will be recorded. I would now like to introduce today's presenter, Dr. Brooks. Dr. Brooks currently serves as the Vice President of Cancer Control Intervention at the American Cancer Society. Dr. Brooks has served as the American Cancer Society's national headquarters since 2000. He's involved in the creation and implementation of strategies to improve the prevention and early detection of cancer and reduce cancer disparities. He also serves as the deputy editor of the Society's peer-reviewed journal, CA, a cancer journal for clinicians. A graduate of the Ohio State University and the Wright State University School of Medicine, Dr. Brooks completed his internal medicine residency and chief residency at Wright State's affiliated hospitals in Dayton, Ohio. He completed the Commonwealth Fund Harvard University Fellowship in Minority Health Policy and holds a master's degree from the Harvard School of Public Health before joining the American Cancer Society. Dr. Brooks practiced primary care medicine and served as the medical director in community health centers in Ohio and in his current hometown of Dallas, Texas. In 2015, Dr. Brooks was honored with the Prevent Cancer Foundation's Laurel Award for National Leadership in Cancer Prevention and Early Detection. Please join me in an extra special reception as we welcome Dr. Brooks back to Nevada. It's been over 2 years since he was in Nevada supporting the Nevada 80% by 2018 Colon Cancer Roundtable, and we are excited to have him back. I would now like to introduce Dr. Brooks.
Well, thank you very much for that introduction, Brandy, and I'm going to launch right in. I'm going to be talking about the current state of the science as it relates to colorectal cancer screening. Start off with a little background about colorectal cancer. Colorectal cancer is the second most common cause of cancer overall in the U.S. Among men and women combined. About 140,000 new cases are expected in 2018. In Nevada, more than 1,100 people will be diagnosed. It's the fourth most common cancer in Nevada. 50,000 plus individuals are going to die across the U.S., 500 plus of those being Nevadans, where it is second only to lung cancer in terms of cause of cancer death. The good news is we've made a lot of progress, and more than 1.2 million Americans are living either with a past diagnosis of colorectal cancer that they've beaten or fighting the disease at present. And incidence and death rates have actually fallen very steadily for more than 30 years now. If you look at this graph, you can see that, as I mentioned, there's been a very steady fall in colorectal cancer deaths. And indeed, in just the last decade, from 2000 to 2011, a 27% drop across the country. Now, this is Nevada data on colorectal cancer mortality, and the scale is different here, but the drop is essentially the same as we see across the U.S. So we're seeing a real improvement in colorectal cancer mortality across the country and in your state. What's leading to that? Well, there are a variety of factors. A lot of it has to do with improvements in treatment, so that individuals, once they're diagnosed, have a much better chance of surviving the disease, in part because we have much more effective surgical techniques, our radiation treatment has improved, and we've got a number of drugs that just weren't available or even dreamed of 30 years ago. But screening also plays a big role in this, because when we screen, we have a greater chance of finding the disease in its earlier stages, and colorectal cancer in its early stage is highly beatable. If patients are found to have cancer at its earliest stage, this stage 0 or stage 1 disease is shown in this illustration, 90% of those folks are going to be alive 5 years later. The 5-year survival for cancer is in its early stages is over 90%. On the other hand, if the disease has spread through the colon wall or spread to other organs by the time it's diagnosed, we're talking about a 12.5% 5-year survival. So it makes a huge difference when we find the disease and start treating it, and we're much more likely to find it early if we are screening. In addition, by finding and removing polyps, we actually prevent the disease from ever occurring. So you can keep your patients from ever having to deal with a cancer diagnosis by doing adequate screening. And it's estimated that more than 500,000 cases of colorectal cancer have been prevented over the last 3 decades through our screening efforts. We have made some real strides with screening. This graph actually shows, or excuse me, this map shows the increases in colorectal cancer screening rates across the country between the years 2012 and 2016. That period coincides with the launch of the American Cancer Society and National Colorectal Cancer Roundtable 80% by 2018 initiative. So in the time since that initiative kicked off, as a nation, we've gone from a 65.5% screening rate to 67.3%. And again, that's based on 2016 data. We're just now, the 2018 data actually won't even be collected until the middle of next year. But just this, what appears at first blush to be a small increase, means that there have been 5 million more people screened as a result of this effort and this boost. And as you can see in your own state, you've had about a 2.9% increase in screening rates. This is the screening rate data on a state-by-state basis. About 61.5% of eligible adults in Nevada are up to date, which unfortunately is the 7th lowest in the U.S. I mean, you're keeping company with states like Louisiana, actually not Louisiana. You are beating your neighbors in New Mexico. You are on par with some of the other states in your region. But if you look in the Northeast, the highest rate in the country, 75.9% in the state of Maine. So there are some significant differences from one part of the country to others, and unfortunately you all are at the low end there in Nevada. So as mentioned, 61.5% of Nevadans were up to date with screening in 2016, which means essentially 4 out of 10 people in your state who should be screened were not up to date. And screening rates are even lower in your minority populations, Hispanics 42%, Asian Pacific Islanders 55%. For Native Americans in the state, we know that the rates are lower. We don't have an accurate figure on exactly what the Native American screening rate is, because the best data is collected by Indian Health Service, and they actually look not at a single state, but at the region that you are involved with. And so it's a mixed set of data, but we know those rates are also persistently low. And then regardless of race or ethnicity, we know that the lowest screening rates occur among individuals who are low income, have low educational levels, and then the absolute lowest rates are in the uninsured. Consequently, it comes as no surprise when we look at data from federally qualified health centers that screening rates in those sites are usually significantly less than for the states that the sites are located in. So while 61.5% of Nevadans overall were up to date with screening for adults treated in FQHCs, only 29.6% of those folks were up to date with screening as of 2016. Now, again, as I just mentioned, minority populations, low income, low educational, uninsured patients all have lower rates everywhere, no matter where they're cared for. And since there is a strong concentration of these patients in the health centers, it's not surprising that health center rates are significantly lower. But that's not to say that they have to remain low. As you can see, again, looking at the Northeast and Maine, 60% of patients in FQHCs are up to date with colorectal cancer screening. And looking at a rural state that faces many of the same kinds of issues as your Nevadan citizens do, North Dakota, as you can see, is up to 52% as of 2016. So it's possible to achieve significantly higher rates with the right sort of focused efforts. One thing to keep in mind is even when in the FQHC environment, but in the general population overall, there has long been the perception, well, the main reason people aren't getting screened is because they don't have insurance and therefore they can't get screened. The reality is 85% of individuals who have never been screened actually have health insurance. And a large proportion of these folks are in that pre-Medicare population between 50 and 64. So that's very important to keep in mind when you see those patients in your practice. A lot of them have insurance and that barrier is removed. Even for the Medicare population, where the vast majority of people 65 and older have insurance, you still find that when you look at low income, low education level, minority patients who are covered by Medicare, their screening rates are significantly less than those of more affluent Medicare patients. So let's talk about what the recommendations are for colorectal cancer screening. First, it's important to recognize there are some individuals who are at significantly higher risk of developing colorectal cancer. These patients need to be identified by your practice because screening recommendations are very different for them. For instance, individuals who have a personal history of adenomatous polyps in the past, a personal history of colorectal cancer, or inflammatory bowel disease, Crohn's or ulcerative colitis. All these conditions confer significantly increased risk. In addition, family history. And family history collection is unfortunately in many practices kind of an afterthought and very limited information is collected. Simply documenting in the chart the patient has a family history of cancer is next to worthless. Documenting a family history of colorectal cancer, if that's all the information that's there, again, not particularly useful. Because what relative is diagnosed and what age that relative is diagnosed makes a big difference. In addition, focusing solely on cancer is also a mistake because having a first-degree family member with an adenoma doubles the risk of your patient developing colorectal cancer. So collecting family history on adenoma is extremely important. For individuals who have any of the risk factors that are listed here, they have a different set of screening recommendations and in general need to start screening 10 years before the age at which their family member was diagnosed. So if you have a patient whose mother was diagnosed with colorectal cancer at 52, that patient needs to begin their screening at 42. In addition, colonoscopy is, for the most part, the only screening test recommended for these increased and high-risk individuals. So you have to identify them to make sure that you start screening on time and with the right test. Now, these are screening recommendations for the average risk population, and these are the U.S. Preventive Services Task Force recommendations that were updated in 2016. You all are likely familiar with these recommendations because your UDS measure in health centers is based primarily on USPSTF recommendations. I will say that until the end of May of this year, the American Cancer Society and the Preventive Services Task Force recommendations were almost identical, But many of you may have seen or heard that as of the end of May, ACS released updated colorectal cancer screening guidelines. And contrary to the long-standing recommendation that screening for average risk people begin at age 50, ACS decided to move that age back by 5 years. So we now recommend that average risk adults age 45 and older begin regular screening for colorectal cancer. We also, in this guideline, emphasized the importance of follow-up testing because there is a significant amount of stool testing going on nowadays, and stool testing is, as I'll talk about later, very high quality and effective approach to colorectal cancer screening. But it is only effective if you complete follow-up for every individual who has an abnormal finding on that stool test. And unfortunately, we know that in many settings, only about half of patients with a positive stool test end up getting a colonoscopy within the next 9 to 12 months. So we're really providing poor quality care when we don't close that loop. Now, in addition to those modifications, the other thing that the ACS did for the first time actually was provide an actual stopping age for colorectal cancer screening. Our guidelines have consistently over the years simply said that screening should be halted when the patient can no longer benefit, which usually means if there is 10 years or less of life expectancy. That's been a very challenging metric for a lot of clinicians to make and a difficult conversation to have with their patients, as in, well, the ACS says you're going to die in 5 years, therefore we don't need to screen you. Puts you all in a very challenging position. Consequently, we looked at a great deal of evidence, and it's pretty clear. The best evidence for a benefit from colorectal screening is for individuals between the ages of 45 and 75. So that is the group for whom screening is relatively unequivocally recommended. However, there are a lot of individuals who are in their late 70s or even early 80s who are in overall good health and particularly may have a spotty screening history or may never have been screened at all. And we know that the risk of developing colorectal cancer actually continues to rise through that period. So our recommendation for individuals 76 through age 85 is that the decision be individualized as to whether or not they should be screened. And that's based, again, on their overall health status. If this is a patient who's on dialysis and the expectation is they're only going to be around for another few years, then they may not benefit. But if you've got a relatively healthy 79-year-old patient who has hypertension, diabetes that are well controlled and is overall doing well, then that's an individual who is at risk of living long enough to suffer and die from colorectal cancer. And you don't want to miss it because you look solely at their age. So individualizing the assessment between 76 and 85 is important. And then finally, for individuals over the age of 85, we recommend against screening. There is really no good evidence that screening individuals in their late 80s and early 90s increases their likelihood of doing well, and there's much greater potential harm actually from doing screening tests in older individuals. With regard to what screening tests to use, the ACS recommendations really have not changed. These are the same tests that we have recommended for the last 10 years, and actually it's the same list of tests that's included in the Preventive Services Task Force guideline, with, again, the proviso that any non-colonoscopy test, if you have a positive finding, that patient needs to be followed up with colonoscopy. So here's a side-by-side comparison of the task force and the ACS recommendations. And as you can see, really the only significant difference between the two is the age at which to begin screening. The Preventive Services Task Force actually looked at very similar data. We use much of the same data that they use. And as I'll talk about earlier, in modeling data was one of the primary drivers in the ACS updated recommendation. The Preventive Services Task Force used the same modelers, and also got a recommendation from 2 of the 3 models that they used to initiate screening beginning at age 45. However, as a very conservative body, the task force decided not to follow that recommendation. The only other difference other than the age is the stronger focus in the ACS guideline on the importance of follow-up colonoscopy for all positive non-colonoscopy tests. So again, the Cancer Society, our expert body, utilized the evidence reviews that had already been done for the Preventive Services Task Force, and then we also commissioned some additional work to be done, but much of the evidence supporting our recommendations is the same as that reviewed since the task force. There also had been some new literature published, and one of the biggest factors was new literature that showed a change in both incidence and mortality rates for colorectal cancer in younger individuals. We took that data, that new data that wasn't available at the time that the task force did their initial modeling, and we commissioned the same modelers to use this new data to assess the potential benefit of changing the starting age for screening. And that's where the recommendation came from. We asked these modelers to look very closely based on these increasing incidence and mortality figures in younger populations to determine whether the risk of the potential benefits of screening younger populations outweighed any potential harms and the possibility of saving lives among this younger age group. So this new data that I'm referencing, much of it came from researchers in the American Cancer Society Epidemiology and Surveillance branch. These are folks who are not at all involved in guideline creation. This work was not done in any way to support our hypothesis that we should start screening earlier. This was simply reporting on trends that have been demonstrated in the literature, actually going back for more than 20 years. And what these trends show is, while we've seen that steady fall I showed you earlier in colorectal cancer incidence and death in people over the age of 50, the screening age that we've used for many years, we've seen a 51% increase in colorectal cancer incidence under the age of 50. And the majority of this increase is occurring in the population between ages 40 and 49, but unfortunately we're even seeing higher rates in people in their 30s and their 20s. This disease is much more, these increases are more prevalent when you look at rectal cancer, but colon cancer rates are rising as well. Now, this is data, again, comparing the incidence rates of colon and rectal cancer among individuals age 45 and age 50 years. And what you can see looking at this graph is that the younger population, the age 45 group, particularly in the years since the early 90s, there's been a steady upward trend. And indeed, in the most recent years, their overall colorectal cancer incidence is similar to that we saw among 50-year-olds back in the early to mid-90s. So we've seen such a dramatic rise that it became clear that in some ways 45 is the new 50 when it comes to colorectal cancer incidence. These are not model-based numbers. These are actual incidence numbers. And what we can see is the proportion of colorectal cancer in adults under age 50 has doubled since 1990. So if we look back at 1990, only 6.4% of the total number of people diagnosed with colorectal cancer in the US were under the age of 50. And as of 2015, that's now 12.4%. And as a matter of fact, in 2014, 43% of the colorectal cancer cases in this younger population were in this 45 to 49-year-old age group. So that group in particular is of great concern. One of the other things that we did in the course of our evidence review was look at the impact on years of life lost of these increasing rates of disease, and found that more than 10% of all years of life lost due to colorectal cancer occur in this group between ages 45 and 49, and which is strikingly more than younger populations. So all of these pieces of data really led us to the conclusion that beginning screening at an earlier age might make sense. And again, those findings were bolstered by the results of the microsimulation modeling that looked at the potential impact of screening. This graph shows the point that I made earlier, that while we've seen a very steady increase in both colon and rectal cancer, colon blue, rectal cancer orange, the rise in rectal cancer is strikingly higher. So the rates of rectal cancer have risen fourfold over the same period of time. That rates of colon cancer have increased by a factor of 2. This is data from a different study that looks at the incidence of colorectal cancer by race and ethnicity. And as you can see, it's been known for many years, or recognized for many years, that rates under age 50 were higher in the African American population. If you go back to 1992, the purple line with the X's, that's the African American population. You can see how much higher their rates were relative to really every other group. But as we've moved forward in time, those rates have remained relatively stable. So African American rates continue to be higher than most other groups. However, you can see all the other groups, the non-Hispanic white, Asian Pacific Islander, and Hispanic populations, have all been trending upward much more rapidly and are sort of closing in on those higher rates that we've seen for many years among African Americans. And then at the top, this orange line, that's the American Indian and Alaska Native population. And rates of under 50 diagnosis have exploded in that population over the last 20 years. So this is an issue that cuts across race and ethnicity. This is the same data in Nevada, specifically in Nevada. The top line, the blue line, colorectal cancer incidence rates, and then the bottom line, the orange line, colorectal cancer death rates, specifically in the population under age 50. And as you can see, these scales again are different than the graphs I showed you earlier, but you see a very steady upward trend in both the cases, new cases, and deaths that's been going on for the last couple of decades. Now, in addition to the under 50 population, some much more recent data also published by colleagues at American Cancer Society along with researchers at National Cancer Institute have shown that it's even among the younger screening age population, that is individuals aged 50 to 54, we're still seeing a very concerning rise. This is actually mortality in this, this is still incidence data. And in particular for rectal cancer, you can see, or actually for both cancers, you can see the red line on top is the 55 to 59-year-old age group, and then the blue line, the 50 to 54-year-old group. And that red line for both colon and rectal cancer is trending downward for that 50 to 59 group. But for the 50 to 54-year-old group, it is actually trending upward for both colon and even more dramatically for rectal cancer. Consequently, we are seeing an unfortunate increase in that younger group that is part of the screening population, that 50 to 54-year-old age group. Now, some of that is because we're not screening those people effectively. And the latest data from Centers for Disease Control showed that less than half of individuals age 50 to 54 are currently being screened for colorectal cancer. Consequently, even a group for whom screening has been recommended for more than 20 years isn't getting screened effectively, and we are seeing what we believe to be one impact of that, which is their rates are going up. So if we now look at not just the under 50 population, but if we look at colorectal cancer under age 55, you can see that between the ages, the years of 1989 and 90, represented by the blue graph, to a more recent period, 2012 to 2013, a very dramatic uptick in the proportion of colorectal cancers diagnosed under age 55. Only 13% of all colorectal cancers occurred in people under 55 back in 1990 or so. That is now up to 20%. And rectal cancer, 29% of rectal cancers now are occurring. Almost 1 in 3 are occurring in people under the age of 55 years. So there is a tremendous amount of work to do. Unfortunately, we don't know why we're seeing these increases. There are a lot of theories, there are a lot of things that have changed in the environment that we believe may be contributing, including rising rates of obesity, and obesity is known to very clearly be related to colorectal cancer risk. The red meat and processed meat intake also is clearly associated with increased colorectal cancer risk, and we see a lot more diets in younger people in particular that are heavily lean toward red and processed meats. Type 2 diabetes is another risk factor, and I don't have to tell any of you in primary care how that disease is exploding. There are also questions about antibiotic use in addition to just over-treating people. We also use antibiotics pretty heavily in the food chain, and questions have been raised as to whether or not that may be making some changes in our microbiome and the gut microflora because of this antibiotic exposure as a result of our food intake. There also is the issue of a striking decrease in the use of aspirin in children going back now for 30 years or more because of Reye's syndrome. But aspirin and other nonsteroidals, we know, are protective against colorectal cancer, and we are younger people are not getting that exposure, the same level of exposure that older generations have received. So a variety of different questions, but no clear answers as to what's causing this. Now, one thing that we do know, I talked to you earlier about those individuals who are at increased or high risk of developing the disease, and we know that those individuals are oftentimes not being picked out in their practices, not being identified as being at increased or high risk, and not having screening initiated at an appropriate time. As a matter of fact, this recent study from Ohio State estimated that of patients under the age of 50 who were diagnosed with colorectal cancer, 14% of those folks had a relative who had an advanced adenoma. And had they been recognized as such, they would have started screening well before age 50 when they were diagnosed. The 14% also had a first-degree relative, and then another 16% had a hereditary condition that could have been associated with colorectal cancer. So overall, in this study, 44% of patients diagnosed with early onset disease potentially could have had their disease prevented or at least found at much earlier stages if they had been recognized and recommended to have earlier onset of their screening. This is actually a relatively high number, but if you look at study after study, about a third of patients are estimated in most studies. About a third of patients under the age of 50 are thought to have a factor that should have led to earlier screening and might have prevented their disease. So a few things in terms of take-home lessons for this. If we're really going to make a big change, one, you need to initiate screening promptly beginning based on ACS recommendations at age 45, or if, as in most health centers, you're going to be following the Preventive Services Task Force recommendations for at least the foreseeable future, beginning screening promptly at 50, because less than half of your patients who are 50 or older are actually up to date. We need better collection and utilization of family history information so that we spot those patients in our practice who need to get started screening earlier. And we also need to make sure that routine genetic testing is occurring with a comprehensive panel for all patients who are diagnosed with early onset colorectal cancer. So if you have a patient, or if one of your patients has a family member who's diagnosed with colorectal cancer before age 50, that patient's tumor needs to be thoroughly tested, and that patient's family needs to, at a minimum, be educated about the increased risk that is conferred on them by being related to that individual, and potentially they may need genetic testing and counseling as well. The other thing that we know is a number of these patients who are diagnosed at younger ages have had symptoms going on for months, at times for years, and have been told repeatedly by their clinicians, oh, well, you're too young for colon cancer, so it must be something else. They don't get the right kind of evaluation. Symptoms, rectal bleeding, abdominal pain, change in bowel habits, weight loss. If you see those symptoms occurring in a 33-year-old person, and you would, if those symptoms were occurring in somebody in their 50s, you'd automatically send them for colonoscopy. That 33-year-old needs that same colonoscopy. Screening guidelines are relevant only to asymptomatic patients. Any patient who has symptoms should be considered as being strongly at risk of colorectal cancer until proven otherwise. So it is imperative that we recognize and address these symptoms quickly, because unfortunately many patients with early onset disease are diagnosed at advanced stages because their symptoms are minimized or ignored for extended periods of time. The National Colorectal Cancer Roundtable has only in the last couple of weeks published a new toolkit designed to help you in your practice do a much better job with collecting family history information, recording it in a way that makes it useful and usable, and provides some guidance on how to manage your patients depending on what information is determined by that family history collection. So I encourage you to go online and take a look at this toolkit and see what pieces of it you can incorporate into your practice. Okay, I'm going to take a pause here and just check and see if there are questions before I launch into the third part of this presentation on screening test.
If you can raise your hand next to your name to let us know if you have a question, that would be great. Thanks.
I can't see the hands raised. If there are no questions, I'm going to move on.
Yeah, I'm not seeing any, Dr. Brooks.
Okay. All right. Well, I'm going to spend the rest of the time talking about screening tests. Now, I showed you those lists earlier. There are a lot of different tests recommended by both the ACS and the Preventive Services Task Force, but the reality is the vast majority of screening is either with colonoscopy or with high sensitivity stool tests. So most of my remarks are going to focus on those. Colonoscopy, everyone's familiar with, long lighted tube with the camera on the end, looks at the entire length of the colon from stem to stern if it is done well, and that's important. I'll be talking a little bit about quality. It has some real advantages in that if it is a completely normal study, it only needs to be repeated 10 years later. And as a matter of fact, patients who have a completely normal colonoscopy, a high quality exam, there's no need to do any other form of screening in the interim. So doing stool testing every 3 years or 5 years between normal colonoscopies is not recommended by anybody, and there is really no evidence supporting it. Colonoscopy also has the advantage of being not just a screening test, but it's a diagnostic test and therapeutic, in that if there is a polyp seen, it is usually removed during that same procedure. So all of these advantages have led colonoscopy to be by far the most commonly used test, screening test in the U.S. But is it the best test? Evidence would not really allow us to label it with that particular moniker. Because colonoscopy, even well-done colonoscopy, misses up to 10% of significant lesions, most of those being large polyps that have a potential to progress to cancer, but some cancers are missed by colonoscopy. It is much more costly on a one-time basis than any of the other screening tests that we have in use, which for patients who are well insured doesn't make a difference, but for patients who have some of these cut rate insurance policies can be very problematic, and for uninsured patients usually will put the procedure totally out of reach. It also, while overall is a very safe test, has more potential for patient injury than any of the screening tests, other screening tests available. It's estimated that somewhere in the range of 1 in 500 to 1 in 1,000 individuals undergoing screening colonoscopy will experience some complication significant enough to need additional care. Sometimes that means a little bit of bleeding, they call their doctor or show up in the emergency room. Sometimes it means a lot of bleeding requiring transfusion. And remember, we're talking about doing this test in people in their 60s and 70s. Many of these patients have other underlying health issues. Cardiovascular and cerebrovascular events are not rare. So all of this needs to be kept in mind when you're making recommendations. But as I mentioned earlier, quality is a very significant issue. And we know from work that's been done over the last 8 to 10 years, quality varies dramatically from one colonoscopist to the next. There are a number of different important quality measures that have been identified, but the one that right now seems to have the most traction as well as the greatest predictive value is the adenoma detection rate. The adenoma detection rate is something that you calculate on a per endoscopist basis. So you look at a gastroenterologist or a surgeon who does a lot of screening colonoscopies, and for every 100 colonoscopies that they do, how many adenomas are they detecting? What the evidence shows us is they should be finding an adenoma in about 1 out of every 4 individuals in whom they're doing a screening colonoscopy. The adenomas are more prevalent in men, so actually about 30% of men and 20% of women should have adenomas detected at the time that they're going through. So if you have a gastroenterologist who does 100 endoscopies over a 2-month period, they should find about 25 adenomas, and their adenoma detection rate would then be 25%. What has been shown in a number of studies, including one very, very large, long Kaiser study, is adenoma detection rates are extremely variable. Even in an environment like Kaiser, where these are all employed physicians using the same equipment, working in the same environment, seeing the same kinds of patients, they were really surprised to find that the adenoma detection rate among their best, their highest performing gastroenterologists was over 50%. So they were finding at least one adenoma in half the patients that they saw. But among lower performers, 7.4%. So as opposed to finding one adenoma out of every 4 patients they were seeing, they were finding adenomas in only 7 out of 100 patients, which was shockingly low. They also were able, because of their very extensive medical record and database, able to go back and look at outcomes. And what they found was for patients who were treated by those gastroenterologists who had the poorest adenoma detection rates, the low adenoma detection rates, patients were twice as likely to develop what's called an interval cancer. That is, they had a, quote, normal colonoscopy, and then their next colonoscopy was scheduled for 10 years later. But before that 10 years, oftentimes in the first 2 or 3 years, they developed a new colorectal cancer. Twice as likely to develop an interval cancer. And with regard to cancer death, patients treated by those endoscopists who had the poor adenoma detection rates, and poor in this case was just less than 20%, patients were 3 times as likely to die from colorectal cancer. So they're not just missing early cancers, they're missing cancers that ultimately end up killing patients. So there have been a number of other studies that have looked at the adenoma detection rate and again found a very strong correlation between the ADR and death, future death from colorectal cancer. So this is a number that is of great importance, and I would encourage you all, if you have multiple endoscopists to whom you can refer your patients, primary care docs need to be asking their endoscopy colleagues whether or not they're tracking and recording and willing to report this kind of quality data, because you want to do what's best for your patients, and what's best is sending your patients places where people know what their quality is and are documenting their quality. Now, there are a number of other important limitations associated with colonoscopy, including the fact that patients have to do more work. The prep in and of itself is a big challenge, but then also in many environments, they have to see the endoscopist in advance of getting their procedure scheduled. So for many of your patients, that may mean taking an extra day off work or half a day just to go see someone and let them poke on their belly and then say, okay, come back in 2 weeks for your procedure. Patients have to have someone accompany them. So there are a lot of hoops that patients have to jump through to get to a colonoscopy. In addition, in your area, in Texas, where I live, there are parts of the state where you may have a 2 or 3 hour trip to get to an endoscopist. And that alone can be a huge barrier. And then there is the very important issue of patient preference. And the reality is, while most primary care clinicians strongly prefer colonoscopy as a screening tool, for patients, not necessarily. When we and others have talked to primary care clinicians about their beliefs and preferences for colorectal screening, colonoscopy is invariably listed as the best test, but they also acknowledge that many of their patients face barriers to getting a colonoscopy, or they're not willing. In spite of this, oftentimes they're still using colonoscopy as the only test that they're recommending. And they don't ask their patients about their preferences or their willingness to try other forms of testing. We also know that anytime you have a practice that is focused solely on colonoscopy, you have a practice that has suboptimal screening rates. When we ask primary care clinicians about stool tests, they will say, well, yes, I use them, but I don't really trust them. I don't believe in them. Their performance is poor. I'm not sure they really work. Those are the sorts of responses. And if we went back 20 years, those responses would be reasonable. Although it should be pointed out that the first data that showed that screening for colorectal cancer actually was effective was based on studies using guaiac-based stool testing, which is old, antiquated technology. And even using those old forms of stool testing, we were able to demonstrate a decrease in the risk of developing and dying from colorectal cancer. But we have now advanced to a point where we have much better stool tests, and in particular, the fecal immunochemical test. The fecal immunochemical test performs at a much higher rate than the old guaiac test. It is much more specific for human blood and blood from the lower portion of the GI tract. And in many of the FITs or IFOBs that are in the marketplace now require collecting only 1 specimen. There are a couple that still require collecting 2 specimens, but this is less than the 3 specimens required for all guaiac tests. And all of the high quality fecal immunochemical tests in the marketplace perform much better than guaiac tests. Overall, this is a meta-analysis that looked at probably 12 different FIT tests in more than 12 different studies, and found overall about a 70% sensitivity for cancer using high quality fecal immunochemical tests. So is it perfect? No, but 70% sensitivity is pretty good for a non-invasive and very low cost test. The Preventive Services Task Force, when they were updating their guidelines a few years ago, I mentioned that they did a number of different models and commissioned modelers. One of the things they modeled was the potential benefit of using different kinds of testing. And what this graph shows is the number of colorectal cancer deaths averted per 1,000 individuals screened. So if you look at the far right, COL10Y, that's colonoscopy every 10 years. So if you have a screening program that uses colonoscopy every 10 years as your main approach, you are going to prevent 24 deaths from colorectal cancer for every 1,000 individuals screened, which is a really, really good number. There's not much that we do in medicine that is going to avoid 24 deaths for every 1,000 people that we expose to whatever this test or treatment is. On the other hand, the other end of the scale, FIT1Y, that's fecal immunochemical testing every year. If you do high quality fecal immunochemical testing, you're going to avert 22 deaths from colorectal cancer for every 1,000 individuals screened. So is 24 better than 22? Sure. Is 24 strikingly better? Is it a huge difference? It's actually not a huge difference when you look at an entire population. And then add to that the fact that this fecal immunochemical testing is much, much more accessible for a lot of populations, as well as the fact that it is strikingly less expensive. You're usually looking at something in the range to $20 to $25 for a fecal immunochemical test versus thousands of dollars for a colonoscopy. So a high quality FIT program can actually save almost as many lives as colonoscopy. The other important issue I mentioned earlier is that of patient preference. And when you ask patients, many patients actually prefer stool testing. This is one of just, there are a number of studies that have looked at this. This study was about 1,200 patients in a safety net clinic, and patients were all educated about why colorectal cancer screening was important. And one group of patients was told, get a colonoscopy, won't cost you anything. Another group was told, do this stool testing. And the third group was told, you can have a colonoscopy, you can do stool testing, you choose. What they found was at the end of the study period, only 38%, less than 4 of 10 people who were offered free colonoscopy actually completed that test. 2/3 of people who were only offered stool testing completed the test. 2/3 of people who were given a choice completed the test. And notice, more people in the choice arm chose stool testing over colonoscopy. But unfortunately, we are not consistently offering stool testing to patients and making them aware of the fact that this is an evidence-based and effective approach. Now, there's important caveats to this, however. Just as there are quality issues with colonoscopy, you also have to do high-quality stool testing, which means, number one, you only use fecal immunochemical test or high-sensitivity guaiac Hemoccult Sensa. You have to be doing a risk assessment because stool testing is not recommended for people at high risk. And every positive stool test must be followed up with colonoscopy. The other thing is collecting the specimen correctly is absolutely essential. And unfortunately, many environments continue to do digital rectal exams and to collect stool specimens for colorectal screening. This is not an evidence-based approach. The largest study that looked at this issue, 2,100 patients were planned to have screening colonoscopy, and before that they had stool specimens collected by rectal exam. 21 cancers were found in that population. Of those, only 2 had a positive digital rectal exam stool sample. So 19 of 21 people who had cancer at the time that rectal exam was done, 19 of 21 were missed. So this is not an evidence-based approach, and digital rectal exam is not an appropriate way to collect specimens for colorectal screening. This information on stool testing that I talked about, and actually a fair amount more, is summarized in this document that you can find on either the National Colorectal Cancer Roundtable website or the American Cancer Society website. So for your colleagues who weren't able to participate in this, making them aware of this tool and this resource, I think, could be very helpful. And then finally, I'm going to talk very briefly about stool DNA testing. Guaiac test and fecal immunochemical test look for blood, so they're dependent on bleeding. Stool DNA tests actually look for DNA changes associated with the cellular matter that's excreted in the stool. So to do a stool DNA assessment, you actually don't have to have blood. And DNA is continuously shed in the stool, whereas bleeding from either polyps or cancer may be intermittent. There is currently only one stool DNA test marketed in the US, and that test is Cologuard. And Cologuard is actually a combination test. It looks for DNA markers, but it also includes a fecal immunochemical test, a high quality FIT. So you get essentially a twofer. And there have been a few studies now that have looked at Cologuard performance, but this study published in the New England Journal is really what pushed them over the top and got them approval for marketing in the US. What they found was 92% of cancers were detected by the combination of stool DNA testing plus fecal immunochemical testing. They did look at just the FIT component alone, and you can see that their FIT found 73.8, 73% of cancer. So very much in line with that number I shared with you earlier about FIT sensitivity. But by adding in the DNA component, you did get a significant bump in the sensitivity. Now, with that bump, you also got a lowering of specificity. So you're more likely to get false positive findings with a Cologuard test than you are with FIT alone, but you get a much higher sensitivity for cancer. So based on this information, FIT DNA testing, Cologuard is now included not only in the ACS guidelines, where it's really been since 2008, but also in Preventive Services Task Force guideline. It's been cleared by the FDA to be marketed as a colorectal cancer screening test. It's recommended based on limited evidence to be repeated every 3 years. It's paid for by Medicare. And since it got added to the Preventive Services Task Force recommendation, more and more private insurers are also covering it. It is important that your patients understand that if Cologuard testing is positive, they have to have a colonoscopy. And because of some glitch in the way the Affordable Care Act is interpreted, while a screening colonoscopy is usually available with no copay and no deductible, if a colonoscopy is done in follow-up to a positive Cologuard or even a positive FIT, now the patient may have a copay. Finally, an important thing to keep in mind from the primary care perspective is patient navigation has been shown to significantly increase the likelihood of patients actually completing their colorectal screening, be that with colonoscopy, FIT testing, or Cologuard. And Cologuard, the company actually has a navigation component that is part of the service provided if you order a Cologuard test. So they will, once you provide them with patient information, the company will send the kit out to the patient and then hound them relentlessly until they get that kit back. So they get pretty high return rates and take some of the navigation component off the hands of primary care practices. I felt the need to add this because as of the beginning of this year, Cologuard as well as CT colonography were added to the UDS screening measure. So you now get credit in your system for screening using not just stool testing and colonoscopy and FlexSig, but Cologuard screening as well as CT colonography. And again, it's expensive out of pocket, but it is covered for your Medicare patients and for many of your commercially insured. We created a number of tools and resources in support of the updated guidelines, so I invite you to go take a look at the American Cancer Society website and look at these tools and resources. And for any kind of cancer-related information for you and your patients, cancer.org/professionals has a wealth of information that you can access and at no cost. That is my final slide, I believe, and I'm happy to entertain any questions.
Dr. Brooks, I do see that we had a question that does Medicaid cover Cologuard?
Medicaid coverage varies from state to state, and I don't have any idea about Nevada Medicaid. I will say that most Medicaid programs are not covering it broadly, but they seem to be taking it on a case-by-case basis. So it's worth at least contacting state Medicaid and seeing whether or not they're willing to cover it.
Okay, do we have any other questions? If you could raise your hand in the your box, and then I can unmute you. If you have any questions.
Hi,
or
this
you can
is
type it in. Hi, June.
Hi, I just wanted to make a note that I posted a lot of the links that Dr. Brooks has reviewed for us today in the chat box, and that will be available to you after the call as well. And I did want to mention on the Medicaid side of things for Nevada, we are, as the American Cancer Society, working closely with our Medicaid division here in Nevada to find out answers to these types of questions and make them available to our partners also. So lots of learning to do in terms of the insurance side of things and Medicaid here in Nevada. So we want to be a source of help for our community in finding out that information and sharing that. And on the call today, we have a lot of health plan representatives here. I see United Health and some others, and you know, lots of questions on that end too. So I don't see any other questions unless somebody's raised their hand.
I do. I see one raised from Ray. I'm going to unmute Ray now.
Awesome.
Hi, Ray.
Hi, this is Ray. I am wondering, so do people have to get a script for all these at-home colon tests or stool samples, or are there like over-the-counter ones that people can buy?
There are no high-quality over-the-counter stool tests. There are a number of tests. There's something called Easy Detect, for instance, that's what's referred to as a throw-in-the-bowl toilet test, where patients defecate and then they drop this tissue and it's supposed to change colors. Those tests are all based on old, very insensitive guaiac technology, and none of them have any published data that would support their use. So everything that I talked about, all the high quality FIT tests, the stool DNA test, require a physician or some healthcare system to provide that testing.
Okay, thank you.
Do you have any other questions for Dr. Brooks?
Let me also mention, there is at least one FIT test that does market itself directly to consumers online. But again, it is a test that does not have any evidence demonstrating its value. Not all FITs are created equal. So that tool that I mentioned about stool test as a stool test resource, we actually list by name or by brand name the 6 different tests that have good evidence in the medical literature. Because the vast majority of FITs out there, unfortunately, don't have evidence showing their ability to detect cancer or polyps.
Thank you.
Don't see any other questions. I'll make this the last question. If anybody has any, you could raise your hand. I don't see any more, so thank you, Dr. Brooks, and thank you to everyone for attending today's webinar. If you have any further questions, you can contact me at bjohns@nvpca, or you can give us a call at 775-887-0417. Once you leave today's webinar, you'll receive a survey on the presentation, and we'd appreciate it if you complete that and provide your feedback. You must finish the survey in order to receive your CEU credit. On behalf of Nevada Primary Care Association, the American Cancer Society, and our presenter, Dr. Brooks, thank you for joining us today, and have a great rest of your day.
Thanks,
Thank you all
everyone.
for the opportunity. Bye-bye.
Thank you. Thank you, Dr. Brooks.